All right, well, thanks so much for the opportunity to speak. It really is a pleasure to be here. This is such a great event, and thanks again, Dr. Lamb, for setting this up. I mean, so I don't have any disclosures. I do want to say I recognize that the audience, this is not, most people here are probably not medical professionals, so I do think that to really talk about advanced approaches in epilepsy surgery, I took out almost all the pictures of surgery, but there might be a couple in there. So if you're going to feel squeamish, maybe this isn't the talk for you. But I wanted to talk about some of the approaches that we use to do some of the surgeries that we used to do through, as Dr. Lamb mentioned, large incisions and disrupting more brain as a result. And now we can do them through somewhat smaller approaches. Also, we'll use some that are, I'll show you some examples where there's actually no incision whatsoever, or you actually don't even go in through any of the skin. So I think an important concept in minimally invasive surgery is that it's not just smaller incision. A smaller incision is great. Dr. Lamb, of course, pointed out that having less bleeding is good from a safety perspective. We know that smaller incisions lead to less pain, which is also great for the child who's recovering. But when we talk about minimally invasive techniques, it's not just smaller incision, less pain, less bleeding. It's also the techniques themselves are different. And I'll show you some examples you'll see of sparing not just pain, but actual brain. And of course, improving outcomes. Again, as Dr. Lamb mentioned, if you're doing a less invasive surgery, but it doesn't treat the seizures as well, it's probably not worthwhile. So you need to demonstrate that it is at least as effective, if not more effective. And I think you'll see some examples of that. So what I'll go through these really fast just to kind of give you a smattering. Burr hole hemispherotomy, this would be a lateral approach as opposed to Dr. Lamb's vertical approach. Burr hole callosotomy, 3 minimally invasive approaches to hypothalamic hamartoma. And we'll just briefly mention subtemporal, eyelid, eyebrow, and endonasal approaches to treating epilepsy. So here you see the typical transsylvian lateral approach, again, different from the vertical approach you just saw an example of. And what you'll see is, and again, sorry, I don't have a pointer here, but all the disconnection when you do a transsylvian approach is all deep. So you don't actually need a large craniotomy, and therefore you don't need a large incision to do deep surgery. You can do it through a small hole. Again, this is just demonstrating sparing of some of the deep structures on the disconnected side. And so here you can see just a variety of some of our patients who have had this burr hole approach. And you can see that you still get the same circumferential disconnection of the deep structures, but you can do it through a very small hole. This is from one of our publications, just kind of demonstrating a burr hole of 15 millimeters, and you can still do your hippocampal resection and the rest of the disconnection. Also from our publication. And what I like about this is from the second day after surgery, and you can see that our patient is eating pancakes because it doesn't hurt to chew, and so she's not on a soft diet. And these are things that a lot of people in this room are familiar with, is the recovery after hemispherotomy. And this is again our patient from our one of our publications on burr hole hemispherotomy, and just what you can do after a hemispherotomy. So, but it's not just about less pain, right? And it's not just about less blood loss, and it's not just about it looking cute. It's that sometimes there are patients who might have a poorer outcome from a more invasive technique. So this is a patient who had severe injury early in life from a trauma. And you can see that, or maybe it's not readily apparent, but this patient has a lot of her old hemicraniectomy scar. She had a large decompression as a result of a trauma many years in the past. That scar has not healed very well. And there's a lot of skin there that doesn't bear hair. And you can see on the MRI that it is extremely thin skin. There are areas with no bone whatsoever, no dura whatsoever. And this is surgery into the ventricle. And so what would happen if you went through her old incision is you would very likely have significant wound healing problem. I should bring up that all the patients that I present here have all given me permission to share their stories and their images. And so for this kind of a patient, I think if you go through the old incision, you're setting her up for maybe a very significant and problematic wound issue. So we can do a 35 millimeter, so that's less than 1.5 inches approach and a burr hole, and you can see it. I think it ended up 37, 38 millimeters there at the end of surgery. This is just another example of someone who's had many surgeries, has very significant scalp healing problems, or has had them in the past after trauma. And so we took a similar approach of, you can find some area of healthy skin, just make a tiny incision, because in somebody who's had a bunch of surgeries, they can be set up for wound healing problems. So that's one of the benefits of burr hole hemispherotomy. And then I just like to sprinkle these in. Our kids love to show us all their RBIs. And that they can swim. They can swim and climb rock walls, and I know this audience is well versed in these types of outcomes. And then we can do the same kind of thing in babies. I would say that this is a baby who's like Dr. Lamb mentioned, we can do this very safely, even in the setting of Sturge-Weber disease, which is a vascular malformation. Again, I don't want to show you too much surgery, but you can see this is more of like a 30 millimeter, but that's barely larger than 1 inch opening. And this this whole hemisphere is a vascular malformation. The child only weighs 13 pounds, but you can get through the whole thing, with minimal blood loss, and you see that, the small incision. And then similar size incisions, even for the most complex, like this one we published, that where the patient doesn't even have a ventricle on that side, which is a critical landmark for all these approaches. And we were able to come up with creative ways. Again, it's all deep surgery. If you look, we took an entry from the back of the head to disconnect this hemisphere, but still, because it's deep surgery, you can do it through a 5 or 6 centimeter incision. It's just more of that case. So, callosotomy. So for patients with very large ventricles, we'll do their complete corpus callosotomy with an endoscope. I'll just play this for you. So here you can see we use a 7 millimeter burr hole, so it's like this large, and we can get through the whole corpus callosum just through an endoscope. And there you can see before, pre-op on the left and post-op on the right. That's a complete callosotomy. So hypothalamic hamartoma is it's a rare disease, but when you're in our field, we see a fair amount of this. There's 3 different ways to use very minimally invasive, newer techniques to take care of this. Here's a child. This is, you don't see you do see my cursor. Here's a pretty large hypothalamic hamartoma right in the midline. And so this is an image like you saw from Dr. Lamb, laser ablation. You can see the heat map on the left, and then you see the estimate of the size of injury on the right. And so what we do is, we make basically a lesion, an injury in the middle of it to try to reduce the seizures. But then here's one where this is the hamartoma here. Here it is in the sagittal view, and here it is in what we call an axial view. And I actually think in this location, laser is less optimized because the learning and memory circuitry would be at risk here. And there's a very tiny little isthmus to try to get there with a laser. So what we did is a tiny little orbitotomy. There you can see it in my hands. Very small approach through an eyebrow incision. Here you can see the optic nerve here, the carotid artery here, and here's the hypothalamic hamartoma in between. And then you can see that we have, a complete resection there, an axial. You can see that it is gone here in the coronal, and you can see that it's gone here in the sagittal. And this is a few weeks after surgery, and that's a year after surgery. And so that's with a little incision by the eyebrow, and she looks great afterwards. And patients after a surgery like this, they really tend to go home 2 days after surgery with certainly much less pain than the old question mark incision. And now, here's the first example of surgery without any incision whatsoever. HIFU, high-intensity focused ultrasound. And so in this case, these are actually two different patients. They look like the same scan, but it's actually two different patients. This is a small residual hypothalamic hamartoma. This patient had had gamma knife about a decade before this surgery. This patient, again, very small residual hypothalamic hamartoma. This patient had had an open surgery about a decade before presentation to our institution. And they were still having these gelastic seizures from their hypothalamic hamartoma. It was disrupting their lives. And one of those two patients was actually having other seizure types too, which we believe to be resultant from the hamartoma. The problem with these specific patients, and I know Dr. Lamb mentioned not just being a hammer and seeing everything as a nail. You want to use different techniques, and that's why you want to be at a comprehensive epilepsy surgery center where you have the full gamut of techniques available to you so that we're using exactly the right technique for the different anatomy. In this location, each of these kids had the same problem, which was one side of their learning and memory circuitry, it's called the fornix and the mammillary body. One side had been injured either from their pathology and or their original surgery, which does happen in this location. And we thought they had one good side. And these are tiny structures, the fornix and the mammillary body. Tiny structures, when you only have one left, it is absolutely critical. You cannot make a new memory if you don't have that one remaining fornix and mammillary body intact. And I thought, at least in my hands, open surgery was probably going to injure that remaining fornix and mammillary body because this hypothalamic hamartoma is growing out of the fornix and mammillary body and displacing it, and it doesn't look normal. I even thought laser, even though laser is very minimally invasive and it's a tiny catheter, I thought it's probably too big and the injury it makes is too imprecise for this tiny, tiny lesion next to something so critical. So for this, we use high-intensity focused ultrasound. And so what that is, here you can see our planning. If you don't look at a lot of brain MRIs, I will probably go on to the next slide. But it's just done in the MRI scanner. There's no incision whatsoever. And you map out with this software that I'm showing you screenshots of. We're mapping out where the actual hamartoma is, where the fornix and the mammillary body are, where our targets are, where we think we've made an injury with the ultrasound. And the proof is in the pudding, of course. What you can see is pre-op on the left, post-op on the right. You see this little light band through the middle of the lesion there on top, and a dark band on this type of MRI. It might be hard to see in this room, but I assure you they're there. And again, proof is in the pudding, and the patients both improve substantially. And here you can just see a figure from our publication on it. So this is a technique where we're just using ultrasound, but we're making an injury. And the thing about HIFU compared to laser is that you can make injuries that are even smaller and even more precise than with laser and certainly than with open surgery. And it's down in the middle of the brain, which makes coming in with open surgery does have significant risks. Yes, sure. That's a great question. Depends on how much of an injury you make. Typically, we're only using HIFU to make the tiniest injuries. And so what we actually find is the injury that you can see on MRI, after surgery and a month after surgery, actually you can't see it a few months later. But what we've found, as well as the Miami group who started doing this, has found that usually the improvement in seizures lasts even though the MRI has normalized. So I can't answer that question because we don't have tissue from there. What we have is MRI. And when you look at the MRI, yes, you still see the injury of, immediately afterwards up to a month out, but not long term. You don't see it. So moving on to subtemporal, especially here on the left side, a lot of people have really important brain. Now we respect the whole brain and we think the whole brain is important, but parts of the brain are really important. And when you're talking about the left temporal lobe, sometimes there's a good reason to leave that alone. And I won't talk about laser ablation of the mesotemporal lobe because Dr. Lamb already touched on it. But sometimes, if laser is always to some degree incomplete because it doesn't do the entire resection. You can only put so many laser probes in, and they're all linear, and the hippocampus and amygdala are not linear, and they're of a complex shape. So there is still a reason sometimes to do a resection. But if we and we know that after a laser ablation, the most common place to have return of seizures is from the residual amygdala and hippocampus. So there are good reasons to take this out. This happens to be the hippocampus that we took out initially. This has not been laser ablated. But you can actually go underneath the temporal lobe so that you don't traverse any of these lateral aspects of the temporal lobe where you have language function and visual function. We can do this for tumors here. Here you see an example of a tumor, again, on this patient's dominant side, language dominant side. You can go underneath the temporal lobe to get the whole thing out. So I'll just have a couple other cases here in the interest of time. When you have a lesion, again, on patient's dominant side, language dominant side, that goes all the way up to the front of what we call the middle fossa, right behind the orbit, and then extends back into the amygdala, sparing the hippocampus. Here you can see in sagittal this bright enhancing nodule. This is actually a tumor inside a focal cortical dysplasia. You can actually do this through a little orbitotomy. There you see in the hand, through this eyelid incision. We can get the whole thing out. Here you see that nodule is gone. Here you see the dysplasia has been removed. It heals up really, really nice. This is about a year after surgery. And we've done this in young kids as young as 4. Here you see this is several months after surgery. Very similar lesion, the medial anterior temporal lobe here. Here you can see on the bottom the postoperative scan. And then we really tried to look to see if we can see it at various angles, and she really looks good after this. And again, very minimal pain with this kind of approach through the eyelid. And other things through the eyebrow, will just kind of show you some examples of the extent of what can be approached. This is, the entire orbitofrontal gyrus and gyrus rectus, right back to the deep structures here, all the way back to the posterior aspect of the orbitofrontal gyrus. And here's another patient where, again, through an eyebrow approach, you can see we can only take exactly what is needed. And this is just a few weeks after surgery. And this is about a year after surgery. You can't really see it. And here you see the extent of resection. This is just another patient, again, who had a large dysplasia in the inferior frontal lobe through an incision like that. This is just a couple weeks after surgery. His eyebrow did grow back. Management of electrical status epilepticus in sleep, also known as spike wave activation in sleep. I'm going to move through this pretty quickly. This is actually a very interesting case report, but also we intraoperative ECOG through the eyebrow, and you can see it healed up really well there. And then the last example, again, incisionless surgery. Here you see something. This is a hamartoma of the olfactory tract, so the smelling nerve. For this patient, had a hamartoma that was causing drug-resistant epilepsy. And here you see in the axial plane, it's right here and right here. So we were able to just put an endoscope in the nose, and here you see it right here, and resect this. And again, the point here, again, is it's not just coming up with a new way of doing it or using new tools. The idea is to get to this without touching the brain at all. not disrupting the brain, not retracting the brain. We were just going right to the lesion. That was the idea behind eyelid incision. That's the idea behind going through the nose. And here you can see, here's just an example. So here's pre-op down here on the right. There's the lesion, post-op up here. And so we get to that without retracting all this brain, without touching the brain, without potentially injuring the brain. So with that, I think we're about at time. So thanks to the Pediatric Epilepsy Surgery Alliance and for all of you for coming, for your interest. Of course, Dr. Lamb, Kelsey Dixon right here, our epilepsy surgery nurse navigator, and the other members of our team. Yeah, thanks for your attention. And I'd love to take any questions along with Dr. Lamb.